So, good morning everyone. Today we will continue with our presentation on the science of the brain. Today will be the fourth part of many to come, inshallah. So, what do we have here? It's an easy one. Okay.
Tooth sign.
What kind of tooth? Incisor tooth, canine tooth, molar tooth sign. What's the diagnosis?
Creutzfeldt-Jakob disease.
No. Jober disease. لا. كروتسفيلد-جاكوب اللي هو الماد كاو. زين. Anyway. Molar tooth. Some other one of the one of the possible differential diagnosis is Jober syndrome. However, what else? What are other names? Let's say other names we might see here. Do you see this one? This thing here? Just a second. What's this? Exactly. From the morning, الريوق طيبة. Hot cross bone. You have this decussation of white, linear white hyperintensities. Sorry?
It's failure of decussation.
No, this hyperintense signal in the brainstem, let's say, it suggests hot cross bun sign. Some people call it a molar tooth sign or cruciform sign, like a cross. Okay? So this is in favor of what diagnosis? Molar tooth Jober syndrome, but hot cross bun sign is not Jober syndrome. What? It is multiple system atrophy, MSA, or cerebellar subtype of multiple system atrophy. Hot cross bun sign is a sign of multiple multiple system atrophy اللي هو MSA, okay, اللي هو type of neurodegenerative disease مثل باركنسون كل هالشغلات ماكو. One of them called MSA, okay, اللي هو هذا. This is the hot cross bun sign. You can see it. It's, or sometimes they call it molar tooth sign. If you look at it this way, it looks like a molar tooth. However, the Jober syndrome is more characteristic than this. So we can see here pontine cerebellar atrophy, cruciform appearance with the preservation of the brachia conjunctiva. On diffusion weighted images, you can see increased signal in the pons and the pons, the brachium of the pons, let's say. The fourth ventricle is a little bit dilated, so it's suggestive of multiple system atrophy, cerebellar subtype. It is an adult onset neurodegenerative disease characterized by Parkinsonism, autonomic failure, cerebellar ataxia, pyramidal signs. The MSA shows selective atrophy of the pons, cerebellum, and middle cerebellar peduncles, atrophy of the middle cerebellar peduncles, and preservation of the superior cerebellar peduncles. The middle is atrophied, the superior is preserved. This will result in what we call fine comb appearance of the folia and fish mouth deformity on the sagittal image. On the sagittal image, there will be something called fish mouth deformity due to preservation of the upper atrophy of the middle and preservation of the upper cerebellar peduncles. Okay? Spinocerebellar ataxia and vasculitis are other rare causes of spinal cord and cerebellar atrophy. Okay? It's not a very common sign to see. We don't see it a lot, but keep in mind when you see this hot cross bun sign, it's indicative of a neurodegenerative disease called MSA. More characteristic in Jober, okay? Yeah, the pontine brachium or peduncle. Brachium means her arm, the arm of the pons. Okay, the brachial artery, brachial, whatever. So, what do we see here? Extraaxial mass in the right CP angle, cerebellopontine angle, with what's this line here? CSF cleft sign or meniscus sign, exactly. So, this indicates what? in extraaxial lesion most likely will be meningioma in this location and this characteristic. So you can see a right cerebellopontine angle mass surrounding T2 hyperintensity. The right pons and the brachium conjunctivum, or the the middle cerebellar peduncle, are compressed and displaced away from the mass, and it's consistent with an extraaxial mass, which in this location at this characteristic it is a meningioma. You can see this is the mass, and there is something surrounding it or separating it from the rest of the brain parenchyma here, indicating it is not from the brain. It is extraaxial, compressing the brain. Okay, so extraaxial masses frequently demonstrate a rim of high T2 signal that separates them from a subjacent brain. This has been proposed to represent intervening cerebrospinal fluid, which is called CSF cleft sign. The classic differential for lesions of the cerebellopontine angle includes what? Meningioma, schwannoma, ependymoma, astrocytoma, metastasis, lipoma, epidermoid, and whenever epidermoid there is arachnoid. Okay? Most of them are schwannoma and meningioma and epidermoids. Okay? Other possible differentials, then we said اللي هو يشمل ependymoma, astrocytoma, metastases, like this is CP angle lesions, not extraaxial lesions I'm talking. مو شرط بس extraaxial. All okay? Include metastasis, astrocytoma, ependymoma, lipoma, كلها included بالdifferential. Okay? So, okay. What do we have here? This is a brain. Axial flare image, exactly. Hyperintense sulci. So, this is called CSF or subarachnoid or sulcal hyperintensity sign. There is a big differential diagnosis. يلا عدوا. Subarachnoid hemorrhage. بعد. Infection like what? Meningitis. Leptomeningeal carcinomatosis. Keep it. You said? Okay, sorry, I didn't hear. Vascular disease. Okay. What else?
It's called cortical enzyme, this one?
No, this is subarachnoid or sulcal hyperintensicy sign. The sulci of the brain here, you can see they are hyperintense. This is a T2 flare, يعني. Okay. It appears more than usual, highlighted. Okay. So this can be seen in subarachnoid hemorrhage, in meningitis, leptomeningeal carcinomatosis, in vascular diseases, supplemental oxygen, propofol. Do you know what's propofol? It's a disease. It's a drug used for induction and maintenance of anesthesia. Okay. شايفين جماعة التخدير ايش عندهم فشي مثل الحليب أبيض. This is propofol. لونه مثل الحليب يعلقوه for maintenance of anesthesia. Okay. Induction and maintenance. It's a GA. GA بس short acting. يعني يطور أصلا يقعد بسرعة لذلك يحبوا يفضلوه جماعة الجي جماعة الانستيزيا. Also prior contrast administration, and it can be an artifact. No. Artifact إذا عندك الفلير بالماشين يعني for some reason the machine does not suppress the CSF properly, you will see hyper intense signal.
But at that time the CSF in the ventricle is also not suppressed.
No, it suppresses it in parts and in part not. For example, one time in my machine, in my clinic, I had this problem exactly. I do coronal flare for the brain as a routine sequence. The last 3 or 4 cuts, always the CSF is there. It's not suppressed for every patient. What does it look like? Well, no. CSF is there in the posterior part of the brain, in the coronal image, okay, and the rest of the brain is suppressed in the front image. So it looks like press. Okay. But you see it كارتيفاكت. When you see it, إذا واحد ما يعرف إنه هذا artifact, okay, can think of press, posterior reversible cerebral. It's just an artifact. I know it because it's my machine. I see it in all patients, but so you have to correct it. Alhamdulillah, I solved this problem, and now I have proper CSF suppression. Okay. So there are various conditions affecting the leptomeninges, CSF, and vasculature can lead to the inadequate nulling or deletion of the subarachnoid signal, what's called flare hyperintensity sign. The causes are, what's happening? Okay, the causes, like we said, as the differential diagnosis here. Various artifacts, they include motion, pulsation, susceptibility artifact. CT should correlate with the finding, and if it is the same findings, it's known as the pseudo subarachnoid hemorrhage sign.
I think it's cortical rim sign, this one.
You can do it cortical
The
rim.
same cause of it.
The differential diagnosis will be the same, exactly. So, this one is easy. What's this?
Cyst with dot.
Cyst with dot. The sign is, the diagnosis is, yeah, good. So the sign is cyst with dot. This is sign. Cyst with dot sign. The diagnosis is a neurocystosarcosis in the vesicular stage, exactly. So we have sign and disease, okay? So you can see right frontal cystic lesion with enhancing cream and punctate internal focus. Differential includes neurocystosarcosis, toxoplasmosis, cystic neoplasms. However, it is very characteristic of a neurocystosarcosis, which is caused by what? The neurocystosarcosis, teniasolium, pork tapeworm. Toxoplasmosis typically have larger and more irregular nodules, which reflects the associated hemorrhage inflammation. Cystic neoplasms are usually more heterogeneous in appearance, may demonstrate enhancing a mural nodule. So to differentiate, if the nodule is larger, it is more in favor of toxoplasmosis. If the regular and edema and enhancement and things like that, mural nodule, it's more in favor of metastasis, okay? Cystic metastasis.
Cyst with mural nodule.
Exactly. Cyst with nodule or mural nodule sign, okay?
And the adult, do we have any the child?
There's a differential diagnosis. Includes hemangioblastoma, infection, and metastasis. Can be a serocytoma in children, in younger age group. Exactly. However, obviously this is an adult, okay?
The nodule in the hemangioblastoma toward the PL surface.
Exactly. In hemangioblastoma, the nodule will be more peripheral, toward the PL surface, not towards the center of the brain. Okay, so it's a cyst with nodule or mural nodule sign. You can all see this enhancing. This is T1 post contrast axial brain. So post contrast image showing markedly enhancing mural nodule in a cyst. Okay. Typically, it's of hemangioblastoma, infection, and metastasis. Hemangioblastoma is at the top of the differential diagnosis. If you see hemangioblastoma, you should look for what? Others, because it might indicate what? Von Hippel-Lindau syndrome. You need at least other findings like pancreatic lesions, renal lesions, cardiac lesions, retina. Okay, you need, I think, at least 2 hemangioblastomas in the brain to diagnose von Hippel-Lindau. But one spinal cord hemangioblastoma is enough to diagnose von Hippel-Lindau. One in the spine is enough to diagnose without anything. In the spinal cord, mu brain. Okay, look for this information. One hemangioblastoma in the spinal cord is very good diagnostic criteria. In the spinal cord, in the brain, it's not enough. At least 2. Okay. So we said these fluid-secreting tumors have mixed solid cystic appearance with the mural nodule representing a tumor and the large adjacent cyst representing the reactive fluid. So the tumor is the nodule. The cyst is just fluid. Okay. In adults, the most common posterior fossa mass is hemangioblastoma and metastasis. Okay. No, with this appearance. Okay.
But the common
and most everywhere, most common mass is metastasis.
No, I
okay.
think the primary is the supratentorial.
Supratentorial primary more common, do you think?
You
think? Everywhere metastasis is more common. Don't worry. Don't think about it. Okay. Hemangioblastoma is hypervascular with intense contrast enhancement. Some flow voids on MR. Infection can also yield solid cystic lesions, but they are usually multiple supratentorial in location. Toxoplasmosis, neurocystosarcosis lesions tend to have more well-defined peripherally enhancing cysts surrounding the parasitic organism. what's called eccentric or concentric target, and cyst with dot sign. Metastasis rarely produces cyst with nodule appearance in the setting of internal necrosis, which tends to be more heterogeneous. Necrosis will be heterogeneous, not okay. وين على ذاك المرة صار discussion على هاي sign. What's this? This is Dawson finger. Previously, the one we saw, I think, which one we used, right? The string of bead sign. It was just dots. These are Dawson fingers. They are no below the onion ring. It's also MS, but more earlier stage. Okay, so it starts with beads sign, here dots at the subcallosal or callosal septal interface, like here, dot 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 dot. Then more necklace sign, or yes, or string of beads or whatever. Then more aggressive or more later stage, there will be these Dawson finger, oval shaped, elongated, pericallosal lesions. Okay, it's like these fingers. Okay. So they contact the corpus callosum, radiating perpendicularly from the lateral ventricles, which is indicating of multiple sclerosis. As we said, it's a chronic demyelinating disorder with temporal and spatial heterogeneity. On the T2 weighted and FLAIR MRI, characteristic plaques are radiating perpendicularly from the lateral ventricle, what's called the Dawson finger. It is both sensitive and specific sign for MS. Isolated cerebral plaques removed from the ependymal veins known as Stenier splashes. Isolated cerebral plaques away from the ependymal surface. You can see. They call it away from the ventricle. Okay. They call it Stenier splashes. Also, it has a differential diagnosis of other demyelinating disease, such as an acute hemorrhagic leukoencephalitis, like what's called Watson-Hurst syndrome, in which linear areas of periventricular hemorrhage may be identified on susceptibility weighted image. You need to do susceptibility weighted to look for hemorrhages. It's much rarer than MS, of course. Other possibilities include vasculitis, which can be associated with perivenular enhancement and multifocal infarcts. Okay? Now, this is a very nice sign if we can keep it in mind. What's this? What's the sign? Is it complete? Incomplete. What do they call it? Dimple. شو تعرفون شو dimple؟ رصعة. هاي أحد عندنا رصعة؟ منو عنده رصعة؟ يلا اللي تشوف الرصعات هاي هنا. يا أساسا يسووها بالضبط جماعة البلاستيك سيرجري، حتى هذه يوم قاموا يسووها. Okay, it's a dimple sign. This dimple sign is very beneficial because it is very characteristic of abscess. You can see here, this is T1 طبعا weighted post contrast image, shows a right frontal lobe lesion with peripheral enhancement, focal medial evagination, or this dimple sign, as well as surrounding vasogenic edema. This is very characteristic of abscess because it's made. Sorry. What do you think? This is the intermifactive MS, but the pattern of enhancement is much more in favor of abscess. Okay. Function does not present as a cystic lesion. Okay, but it does not present as a ring or cystic or rounded lesion. Infarction takes a segment. Territory. Can show enhancement, but it does not. It's not rounded, not oval shape. Magic Doctor L again, but we added L. We added L. Lymphoma. Okay, so cerebral abscesses may result from penetrating trauma, surgery, direct spread of adjacent infection, or hematogenous dissemination. Various bacteria can be fungal, bacterial, parasitic pathogens have been described. The time of formation of a mature abscess range from 2 weeks to few months. Organized abscesses demonstrate smooth peripheral enhancing rim of fibrous collagen, which tend to be slightly thinner on the ventricular side than along the cortical margin. Okay? Possibly due to difference between white and gray matter perfusion, it's thinner on the ventricular side, thicker on the cortical side. This might lead to later rupture into the ventricular system because it's thin not towards the ventricle, which is a very bad sign because it will lead to CSF spread of the pulse and the pathogen all over the central nervous system. Over time, the abscess may evaginate or dimple toward the ventricular margin. دائما dimple على ventricular margin. Okay. We said the rupture will can lead to spread of infection, which greatly increase morbidity and mortality. Okay. This is a lesion, and after a while, the same lesion, the same patient, I mean, disappeared.
Contrast? Both of them are contrast?
Yeah. Both of them are contrast. Like today and after few weeks, for example. The tumor is gone, disappeared. This is what's called disappearing or vanishing tumor or ghost tumor or sentinel lesion. Okay? It also has a differential, which includes CNS lymphoma and tummy factive demyelination. Okay? After treatment, gone, disappeared. Okay?
Maybe both of them respond to steroid.
Exactly. So, in the first image, you can see lobulated enhancing left peri or landing mass with surrounding vasogenic edema. Following steroid treatment, there is complete resolution of the mass. Disappeared, vanished. It has one of two, either CNS lymphoma or tummy factive demyelination. The primary central nervous system lymphoma occur in immunocompromised patients and immunocompetent individual after the 5th decade. Okay, the most common is non-Hodgkin B cell type. Due to tumor hypercellularity, lesions typically are what on the CT? Hyperdense on the CT scan. Okay, and hypointense on T2. Exactly, due to hypercellular. In general, it is iso to hypo on the T2 MRI and hyperdense on the CT scan because it's densely packed cells. Okay, the enhancement pattern is homogeneous and solid in immunocompetent patients, but more heterogeneous and ring in immunocompromised. So if it's ring enhancing, ugly looking, more in favor immune compromised. If it is nice, smooth, homogeneous, more likely immune competent, especially after the 5th decade. The lesions can be multifocal, can involve the brain parenchyma, the vessels, ependyma, meninges. This lymphoma responds dramatically to steroid and radiotherapy. Yeah, amazing response. They just give a steroid, voila, nothing. Okay? It's what's called ghost tumor. But generally, this is followed by recurrence and systemic involvement within 3 years. لا تفرح. Within 3 years, it will recur with systemic involvement. Recent studies suggest a minimum of 5 years follow-up for screening for disease relapse. Okay? Granulomatous and demyelinating diseases can regress with steroids but have a different clinical presentation and imaging appearance. Tumors other than lymphoma may decrease in size because of reduced inflammation and edema but should not disappear completely. They reduce due to edema, loss of reduced edema. طبعا خصوصا بالbrain lesions that is associated with marked edema like metastasis, for example. Though they are always metastasis, GBM also marked edema. They give them steroids, especially dexamethasone, mannitol, to decrease edema of the brain, which is improves the patient's quality of life. Okay, we have some time left. Let's see another sign. What's this? Okay, ring. What else? Ring and donut sign. Exactly. Oh, it's the same sign. Different names for the same sign. So this is an axial T1 image, show a right coronal radiata mass with complete ring enhancement. No dimple, no nothing, no incomplete ring, okay, things like that. It has a big differential diagnosis like metastasis, abscess, GBM, radiation necrosis, CNS lymphoma if immunocompromised, and toxoplasmosis if immunocompromised. Okay, which is the magic Dr. L. Okay, we heard a lot of this Dr. L. The ring enhancing pattern, organized abscesses have smooth rim enhancement with internal reduced diffusion. GBM show a thick irregular rim enhancement with heterogeneous internal enhancement. Infarcts rarely demonstrate ring enhancement unless located in the deep gray matter. It's just the magic Dr. L is going over it, okay? Contusions infrequently have ring enhancement, may show susceptibility from internal hemorrhage. Tamifactive demyelination demonstrate incomplete ring along the active or the leading edge of the disease. Just the active part is enhancing. Radiation necrosis has variable enhancement pattern. Encephalomalacia can cause a subbubble appearance. In immunocompromised patients, the two ring enhancing lesions such as CNS lymphoma or toxoplasmosis. Well, treatment is often empiric, they give them both.
They will give antitoxo, I think.
Give both of them.
They respond. Okay,
you'll give a steroid, nothing else. To decrease the edema. Okay? Also, additional imaging can help in the diagnosis to differentiate toxo from lymphoma.
Size, if it's large, it's a figure of single.
Okay, what other imaging can help to differentiate? Nuclear. SPECT, exactly. What kind of SPECT? Thallium 201. Use thallium. What does it show?
It's uptake by lymphoma.
Uptake, increased intake of lymphoma and decreased intake by toxoplasmosis. MR spectroscopy can help, which increased choline in lymphoma and decrease in toxoplasmosis. And MR perfusion can help centrally increased cerebral blood volume in lymphoma and decreased in toxoplasmosis. Okay? Good. Nice. Okay, I think we'll have this last sign for today. This is called lacy pattern or dot-like pattern. Lacy. Lace يعني شريط. Some, yeah, exactly. Lace-like pattern in sarcoidosis in the phalanges, in the bone. Okay. So what does, there are two lesions that demonstrate this sub-bubble appearance, dot-like lacy pattern in the brain. Two lesions. Oligodendroglioma and oligoastrocytoma. Okay, both of them are oligo. واحدة dendroglioma, واحدة astrocytoma. Okay, can give you this pattern. You can see this ورق الحيطان. Okay, كاغذ ديوار. Okay. بالشوارع موجود في كل مكان يسوي. So it's a T1 weighted image show hypointense mass extending from the right frontal horn to the subcortical white matter. There are faint internal foci of enhancement. Okay, طبعا this post contrast can be either due to oligodendroglioma or oligoastrocytoma. We'll talk a little bit about them. The oligodendroglioma is a glial neoplasm, typically affects male in 4th to 7th decade. Okay, male in 4th to 7th decade. WHO classified it into a well-differentiated and anaplastic subtypes. In addition, mixed gliomas can occur, with the most common being oligoastrocytoma. Okay, the most frequent location is in the frontal lobe, followed by temporal lobe. We have here the frontal lobe type.
Oligoastrocytoma is in the ventricle, while oligodendroglioma
Yeah.
is in the periphery.
Yeah, we'll talk about it. Lesions tend to be superficial with involvement of the cortex and the subcortical white matter, producing scalloping of the overlying calvarium because long-standing process. Margins are generally well circumscribed. Internal contents are T2 hyperintense, multilocular with bubbly appearance. Internal dot-like or lacy enhancement is a characteristic feature, though some lesions may not enhance at all. The presence of contrast enhancement indicates higher tumor grade and worse patient prognosis. Some of them don't enhance at all. The presence of, the more it enhances, the worse prognosis. كل ما تاخذ enhancement أكثر كل ما أسوأ. Okay. Other imaging features include calcification and occasional hemorrhage, but it's very unlikely that hemorrhage or calcification can take this appearance. It's usually either oligodendroglioma or oligoastrocytoma. Okay?
Vessels. Signified.
Yeah, but vessels is not present with the mass-like lesion. Okay?
Usually shows calcification.
On CT scan, it shows calcification, exactly, with
Malignant tumor that cause calcification is
oligodendroglioma, so bubble appearance, exactly.
That's the most common.
Okay? Nice. I think we should stop here and we'll continue next week.